The world over, businesses exist to solve people's problems. And when a business is about providing healthcare, we need to be responsive and adaptive to changing needs of the society, providing the right drugs for the most effective treatment. We have witnessed changing lifestyles, changes in food supply chain, and overall changes in the environment, all of which are reflected in the society's health and in our products. The idea of Alkem was born in 1973, a time when infections were the biggest threat to humanity. We brought several prominent brands of anti-infectives to the market, which continue to be popular with doctors to date. With over 700 brands, we are number one in anti-infectives in India and have also been witnessing constant growth in other therapeutic areas such as gastrointestinal, pain and analgesics, vitamins, minerals and nutrients, neuropsychiatry, dermatology and cardiodiabetology. We are making steady inroads into the exciting OTC products market with pain relief balms, pregnancy test kits and condoms. Constant innovation has ensured that our products succeed at a global level. Today, our markets extend to more than 50 countries worldwide. We are growing rapidly in majority of the markets through our subsidiaries. Comes from the vision and direction of our legendary founders, Mr. Samprada Singh and Mr. Basudev Narayan Singh, who are among the most respected personalities in the pharma industry. Serving humanity involves serving people in different ways, and our CSR initiatives have impacted communities in myriad ways, from providing healthcare to encouraging sports. Alkem undertakes diverse community initiatives to uplift the disadvantaged sections of the society. We will always be committed to provide people with smiles, health and unlimited opportunities to achieve their dreams. Alkem Laboratory, extending life care beyond boundaries.
Doctor, your trust and confidence while prescribing a brand comes from its quality, thereby consistency in delivering results. Delivering a quality product that ensures consistent results needs to pass through stringent manufacturing processes. At Alkem, Zone is manufactured at state-of-the-art WHO and GMP certified Sikkim plant. Each and every vial of Zone passes through 50 different quality checks at different manufacturing steps. 11 checks done at cleaning, sterilization and drying of machine parts. 9 checks done at washing of vials. 9 checks done at sterilization and depyrogenation. 5 checks done at blending. 10 checks done at vial filling. 6 checks done at dispensing. Moreover, Zone is powered with advanced nanotechnology, which achieves particle size of less than 30 microns and helps in rapid and deeper penetration into infected tissues. 50 stringent quality checks powered with cutting-edge nanotechnology give Zone the X factor. Doctor, prescribe Alkem's #1 prescribed injectable antibiotic Zone with trust and confidence. Zone, the first shot, sure shot injectable antibiotic in typhoid fever, gastroenteritis, RTI, UTI and meningitis.
The world over, businesses exist to solve people's problems. And when a business is about providing healthcare, we need to be responsive and adaptive to changing needs of the society, providing the right drugs for the most effective treatment. We have witnessed changing lifestyles, changes in food supply chain, and overall changes in the environment, all of which are reflected in the society's health and in our products. The idea of Alkem was born in 1973, a time when infections were the biggest threat to humanity, we brought several prominent brands of anti-infectives to the market, which continue to be popular with doctors to date. With over 700 brands, we are number one in anti-infectives in India and have also been witnessing constant growth in other therapeutic areas such as gastrointestinal, pain and analgesics, vitamins, minerals and nutrients, neuropsychiatry, dermatology and cardiodiabetology. We are making steady inroads into the exciting OTC products market with pain relief balms, pregnancy test kits and condoms. Constant innovation has ensured that our products succeed at a global level. Today, our markets extend to more than 50 countries worldwide. We are growing rapidly in majority of the markets through our subsidiaries and strategic acquisitions. To constantly meet the demands of the global population, we have 20 manufacturing units in India and in the United States. Since inception, Alkem has maintained a strong focus on research, for we believe that there is always a better solution. Today, over 500 scientists are working actively to create more efficient formulations across various therapeutic areas. Through its journey of 4 decades, Alkem has steeply risen to become the 5th largest pharmaceutical company in India. The thrust of the company's success comes from the vision and direction of our legendary founders, Mr. Samprada Singh and Mr. Basudev Narayan Singh, who are among the most respected personalities in the pharma industry. Serving humanity involves serving people in different ways, and our CSR initiatives have impacted communities in myriad ways, from providing healthcare to encouraging sports. Alkem undertakes diverse community initiatives to uplift the disadvantaged sections of the society. We will always be committed to provide people with smiles, health and unlimited opportunities to achieve their dreams. Alkem Laboratory, extending life care beyond boundaries.
Doctor, your trust and confidence while prescribing a brand comes from its quality, thereby consistency in delivering results. Delivering a quality product that ensures consistent results needs to pass through stringent manufacturing processes. At Alkem, Zone is manufactured at state-of-the-art WHO and GMP certified Sikkim plant. Each and every vial of Zone passes through 50 different quality checks at different manufacturing steps. 11 checks done at cleaning, sterilization and drying of machine parts. 9 checks done at washing of vials. 9 checks done at sterilization and depyrogenation. 5 checks done at blending. 10 checks done at vial filling. 6 checks done at dispensing. Moreover, Zone is powered with advanced nanotechnology, which achieves particle size of less than 30 microns and helps in rapid and deeper penetration into infected tissues. 50 stringent quality checks powered with cutting-edge nanotechnology give Zone the X factor. Doctor, prescribe Alkem's #1 prescribed injectable antibiotic Zone with trust and confidence. Zone, the first shot, sure shot injectable antibiotic in typhoid fever, gastroenteritis, RTI, UTI and meningitis.
The world over, businesses exist to solve people's problems. And when a business is about providing healthcare, we need to be responsive and adaptive to changing needs of the society, providing the right drugs for the most effective treatment. We have witnessed changing lifestyles, changes in food supply chain, and overall changes in the environment, all of which are reflected in the society's health and in our products. The idea of Alkem was born in 1973, a time when infections were the biggest threat to humanity. We brought several prominent brands of anti-infectives to the market, which continue to be popular with doctors to date. With over 700 brands, we are number one in anti-infectives in India and have also been witnessing constant growth in other therapeutic areas such as gastrointestinal, pain and analgesics, vitamins, minerals and nutrients, neuropsychiatry, dermatology and cardiodiabetology. We are making steady inroads into the exciting OTC products market with pain relief balms, pregnancy test kits and condoms. Constant innovation has ensured that our products succeed at a global level. Today, our markets extend to more than 50 countries worldwide. We are growing rapidly in majority of the markets through our subsidiaries and strategic acquisitions. To constantly meet the demands of the global population, we have 20 manufacturing units in India and in the United States. Since inception, Alkem has maintained a strong focus on research, for we believe that there is always a better solution. Today, over 500 scientists are working actively to create more efficient formulations across various therapeutic areas. Through its journey of 4 decades, Alkem has steeply risen to become the 5th largest pharmaceutical company in India. The thrust of the company's success comes from the vision and direction of our legendary founders, Mr. Samprada Singh and Mr. Basudev Narayan Singh, who are among the most respected personalities in the pharma industry. Serving humanity involves serving people in different ways, and our CSR initiatives have impacted communities in myriad ways, from providing healthcare to encouraging sports. Alkem undertakes diverse community initiatives to uplift the disadvantaged sections of the society. We will always be committed to provide people with smiles, health and unlimited opportunities to achieve their dreams. Alkem Laboratory, extending life care beyond boundaries.
Doctor, your trust and confidence while prescribing a brand comes from its quality, thereby consistency in delivering results. Delivering a quality product that ensures consistent results needs to pass through stringent manufacturing processes. At Alkem, Zone is manufactured at state-of-the-art WHO and GMP certified Sikkim plant. Each and every vial of Zone passes through 50 different quality checks at different manufacturing steps. 11 checks done at cleaning, sterilization and drying of machine parts. 9 checks done at washing of vials. 9 checks done at sterilization and depyrogenation. 5 checks done at blending. 10 checks done at vial filling. 6 checks done at dispensing. Moreover, Zone is powered with advanced nanotechnology, which achieves particle size of less than 30 microns and helps in rapid and deeper penetration into infected tissues. 50 stringent quality checks powered with cutting-edge nanotechnology give Zone the X factor. Doctor, prescribe Alkem's #1 prescribed injectable antibiotic Zone with trust and confidence. Zone, the first shot, sure shot injectable antibiotic in typhoid fever, gastroenteritis, RTI, UTI and meningitis.
The world over, businesses exist to solve people's problems. And when a business is about providing healthcare, we need to be responsive and adaptive to changing needs of the society, providing the right drugs for the most effective treatment. We have witnessed changing lifestyles, changes in food supply chain, and overall changes in the environment, all of which are reflected in the society's health and in our products. The idea of Alkem was born in 1973, a time when infections were the biggest threat to humanity. We brought several prominent brands of anti-infectives to the market, which continue to be popular with doctors to date. With over 700 brands, we are number one in anti-infectives in India and have also been witnessing constant growth in other therapeutic areas such as gastrointestinal, pain and analgesics, vitamins, minerals and nutrients, neuropsychiatry, dermatology, and cardiodiabetology. We are making steady inroads into the exciting OTC products market with pain relief balms, pregnancy test kits, and condoms. Constant innovation has ensured that our products succeed at a global level. Today, our markets extend to more than 50 countries worldwide. We are growing rapidly in majority of the markets through our subsidiaries and strategic acquisitions. To constantly meet the demands of the global population, we have 20 manufacturing units in India and in the United States. Since inception, Alkem has maintained a strong focus on research, for we believe that there is always a better solution. Today, over 500 scientists are working actively to create more efficient formulations across various therapeutic areas. Through its journey of 4 decades, Alkem has steeply risen to become the 5th largest pharmaceutical company in India. The thrust of the company's success comes from the vision and direction of our legendary founders, Mr. Samprada Singh and Mr. Basudev Narayan Singh, who are among the most respected personalities in the pharma industry. Serving humanity involves serving people in different ways, and our CSR initiatives have impacted communities in myriad ways, from providing healthcare to encouraging sports. Alkem undertakes diverse community initiatives to uplift the disadvantaged sections of the society. We will always be committed to provide people with smiles, health, and unlimited opportunities to achieve their dreams. Alkem Laboratory, extending life care beyond boundaries.
Doctor, your trust and confidence while prescribing a brand comes from its quality, thereby consistency in delivering results. Delivering a quality product that ensures consistent results needs to pass through stringent manufacturing processes. At Alkem, Zone is manufactured at state-of-the-art WHO and GMP certified Sikkim plant. Each and every vial of Zone passes through 50 different quality checks at different manufacturing steps. 11 checks done at cleaning, sterilization and drying of machine parts. 9 checks done at washing of vials. 9 checks done at sterilization and depyrogenation. 5 checks done at blending. 10 checks done at vial filling. 6 checks done at dispensing. Moreover, Zone is powered with advanced nanotechnology, which achieves particle size of less than 30 microns and helps in rapid and deeper penetration into infected tissues. 50 stringent quality checks powered with cutting-edge nanotechnology give Zone the X factor. Doctor, prescribe Alkem's #1 prescribed injectable antibiotic Zone with trust and confidence. Zone, the first shot, sure shot injectable antibiotic in typhoid fever, gastroenteritis, RTI, UTI, and meningitis.
The world over, businesses exist to solve people's problems. And when a business is about providing healthcare, we need to be responsive and adaptive to changing needs of the society, providing the right drugs for the most effective treatment. We have witnessed changing lifestyles, changes in food supply chain, and overall changes in the environment, all of which are reflected in the society's health and in our products. The idea of Alkem was born in 1973, a time when infections were the biggest threat to humanity. We brought several prominent brands of anti-infectives to the market, which continue to be popular with doctors to date. With over 700 brands, we are number one in anti-infectives in India and have also been witnessing constant growth in other therapeutic areas such as gastrointestinal, pain and analgesics, vitamins, minerals and nutrients, neuropsychiatry, dermatology and cardiodiabetology. We are making steady inroads into the exciting OTC products market with pain relief balms, pregnancy test kits and condoms. Constant innovation has ensured that our products succeed at a global level. Today, our markets extend to more than 50 countries worldwide. We are growing rapidly in majority of the markets through our subsidiaries and strategic acquisitions. To constantly meet the demands of the global population, we have 20 manufacturing units in India and in the United States. Since inception, Alkem has maintained a strong focus on research, for we believe that there is always a better solution. Today, over 500 scientists are working actively to create more efficient formulations across various therapeutic areas. Through its journey of 4 decades, Alkem has steeply risen to become the 5th largest pharmaceutical company in India. The thrust of the company's success comes from the vision and direction of our legendary founders, Mr. Samprada Singh and Mr. Basudev Narayan Singh, who are among the most respected personalities in the pharma industry. Serving humanity involves serving people in different ways, and our CSR initiatives have impacted communities in myriad ways, from providing healthcare to encouraging sports. Alkem undertakes diverse community initiatives to uplift the disadvantaged sections of the society. We will always be committed to provide people with smiles, health and unlimited opportunities to achieve their dreams. Alkem Laboratory, extending life care beyond boundaries.
Doctor, your trust and confidence while prescribing a brand comes from its quality, thereby consistency in delivering results. Delivering a quality product that ensures consistent results needs to pass through stringent manufacturing processes. At Alkem, Zone is manufactured at state-of-the-art WHO and GMP certified Sikkim plant. Each and every vial of Zone passes through 50 different quality checks at different manufacturing steps. 11 checks done at cleaning, sterilization and drying of machine parts. 9 checks done at washing of vials. 9 checks done at sterilization and depyrogenation. 5 checks done at blending. 10 checks done at vial filling. 6 checks done at dispensing. Moreover, Zone is powered with advanced nanotechnology, which achieves particle size of less than 30 microns and helps in rapid and deeper penetration into infected tissues. 50 stringent quality checks powered with cutting-edge nanotechnology give Zone the X factor. Doctor, prescribe Alkem's #1 prescribed injectable antibiotic Zone with trust and confidence. Zone, the first shot, sure shot injectable antibiotic in typhoid fever, gastroenteritis, RTI, UTI and meningitis.
The world over, businesses exist to solve people's problems. And when a business is about providing healthcare, we need to be responsive and adaptive to changing needs of the society, providing the right drugs for the most effective treatment. We have witnessed changing lifestyles, changes in food supply chain, and overall changes in the environment, all of which are reflected in the society's health and in our products. The idea of Alkem was born in 1973, a time when infections were the biggest threat to humanity. We brought several prominent brands of anti-infectives to the market, which continue to be popular with doctors to date. With over 700 brands, we are number one in anti-infectives in India and have also been witnessing constant growth in other therapeutic areas such as gastrointestinal, pain and analgesics, vitamins, minerals and nutrients, neuropsychiatry, dermatology, and cardiodiabetology. We are making steady inroads into the exciting OTC products market with pain relief balms, pregnancy test kits, and condoms. Constant innovation has ensured that our products succeed at a global level. Today, our markets extend to more than 50 countries worldwide. We are growing rapidly in majority of the markets through our subsidiaries and strategic acquisitions. To constantly meet the demands of the global population, we have 20 manufacturing units in India and in the United States. Since inception, Alkem has maintained a strong focus on research, for we believe that there is always a better solution. Today, over 500 scientists are working actively to create more efficient formulations across various therapeutic areas. Through its journey of 4 decades, Alkem has steeply risen to become the 5th largest pharmaceutical company in India. The thrust of the company's success comes from the vision and direction of our legendary founders, Mr. Samprada Singh and Mr. Basudev Narayan Singh, who are among the most respected personalities in the pharma industry. Serving humanity involves serving people in different ways, and our CSR initiatives have impacted communities in myriad ways, from providing healthcare to encouraging sports.
Yeah, good evening, doctors. Today is honorable medical fraternity, as well as all the medical fraternity, consulting physician, intensivists, those are connected to us online. A warm welcome to all of you for a Star Strong webinar, which happens to be the first of its kind initiative by Alkem Laboratories to create an awareness and to ensure there is antibiotic which has to be used in a judicious way, in an appropriate way, and at an appropriate dose. It's my great honor and privilege to welcome you all for this webinar. Myself, Alhad Arun Joshi, Senior Marketing of Alkem. At the outset, I would like to give my sincere thanks to all my Calcutta team for their rigorous work, consistent follow-up, and persuasion, which has helped us to make this program happen. This program was supposed to be happening on 14th of July, but because of some technical reasons, we had to actually postpone that. However, I once again apologize for all those doctors, those are online connected to us. So with this, I would like to quickly take you all to the Alkem, what is Alkem all about, and a quick snapshot about the Alkem. Alkem Laboratories extending life care beyond the boundaries. That is what we have been following. Alkem at a glance, if you look at this Alkem, we have 49 years of experience. Rather, this year we are celebrating the 50 years. So this is a very auspicious year for us. We are actually a top 5th company in the pharmaceutical market, Indian pharmaceutical market. Our presence is in more than 40 countries. We are number one in anti-infectives. We have got 800 odd brands, 19 manufacturing facility, 123 countries wherein our new products are being registered, and our 500 scientists which are working day in and day out to come up with the best of the products, molecule processes, and state-of-the-art drug delivery medications in the country. And the biggest strength of Alkem is the reach. We have as high as 16,500 people. Those are actually situated nook and counter to ensure the best of the products and services across the country. Leadership, yes, Alkem has a leadership in Indian pharmaceutical industry and beyond. In terms of quality, as an infinite service that we definitely cares, and hard work that we endures. These are our top 9 values, what we have been following day in and day out. Few like safety, quality, honesty, responsibility, compassion, fairness, respect, adaptability, and gratitude. Nonetheless, out of almost 34 distinct therapy in Indian pharmaceutical market, we have got presence in more than 12 therapies, and we are dominant position in the growing market as well as in the various therapeutic segments. As regards to our capabilities, yes, we have got manufacturing units at different places, namely at Baddi and at various places like Pune, Sikkim, and R&D, which happens to be the greatest lever for the Alkem's growth. That is 500 odd scientists, 6 global R&D centers in terms of formulation development, BA and BE studies, biologicals, and API research. Apart from India, we have got overseas operations in more than 40 countries. These are the few to name over. I'm very happy and very glad to share with you that Alkem happens and been awarded as the great place to work as a certification and recognized as one of the top 5 best workplaces in biotechnology and the pharmaceutical in India by the prestigious Great Place to Work Institute in India. And very importantly, as I said in the beginning, that this year is very auspicious year for us. All of us are celebrating 50 years. Our country is also celebrating the Amrut Mahotsav, that is 75 years. So similarly, Alkem is also celebrating the 50 years. And both the things have happened in the month of August. So on this auspicious note, we once again extend our gratitude to get connected with the Alkem. And nonetheless, I cannot complete my corporate presentation without remembering late Mr. Sampradaya Singh, that co-founder of Alkem Laboratories, who always used to say that only determined mind can find out the ways to succeed. And this is what the greatest motivation, this is what is the greatest driving force for all of us to work day in and day out. So with this, once again, a warm welcome, and I will quickly request to run our corporate video, Alkem corporate video.
The world over, businesses exist to solve people's problems. And when a business is about providing healthcare, we need to be responsive and adaptive to changing needs of the society, providing the right drugs for the most effective treatment. We have witnessed changing lifestyles, changes in food supply chain, and overall changes in the environment, all of which are reflected in the society's health and in our products. The idea of Alkem was born in 1973, a time when infections were the biggest threat to humanity. We brought several prominent brands of anti-infectives to the market, which continue to be popular with doctors to date. With over 700 brands, we are number 1 in anti-infectives in India, and have also been witnessing constant growth in other therapeutic areas such as gastrointestinal, pain and analgesics, vitamins, minerals and nutrients, neuropsychiatry, dermatology and cardiodiabetology. we are making steady inroads into the exciting OTC products market with pain relief balms, pregnancy test kits, and condoms. Constant innovation has ensured that our products succeed at a global level. Today, our markets extend to more than 50 countries worldwide. We are growing rapidly in majority of the markets through our subsidiaries and strategic acquisitions. To constantly meet the demands of the global population, we have 20 manufacturing units in India and in the United States. Since inception, Alkem has maintained a strong focus on research, for we believe that there is always a better solution. Today, over 500 scientists are working actively to create more efficient formulations across various therapeutic areas. Through its journey of 4 decades, Alkem has steeply risen to become the 5th largest pharmaceutical company in India. The thrust of the company's success comes from the vision and direction of our legendary founders, Mr. Samprada Singh and Mr. Basudev Narayan Singh, who are among the most respected personalities in the pharma industry. Serving humanity involves serving people in different ways, and our CSR initiatives have impacted communities in myriad ways, from providing healthcare to encouraging sports. Alkem undertakes diverse community initiatives to uplift the disadvantaged sections of the society. We will always be committed to provide people with smiles, health, and unlimited opportunities to achieve their dreams. Alkem Laboratory, extending life care beyond boundaries.
Yeah, thank you so much. Yeah, this happens to be the 4th Star Strong webinar for this current financial year. We started our webinar from Mumbai and then followed by Delhi and Chennai. We got an overwhelming response. We could able to connect with the doctors and try to engage them in a very scientific manner and in a way that what exactly the ceftriaxone and why ceftriaxone high doses are recommended in intensive care. So today we are really honored and privileged to have Dr. Shushruth Bandyopadhyay with us to introduce today's eminent doctor, Dr. Shushruth Bandyopadhyay. I would request our medical advisor, Dr. Pooja Vaidya, to please come forward and please introduce Dr. Shushruth Bandyopadhyay to the entire audience. Over to you, Dr. Pooja.
Thank you, Alhaj. Good evening, everyone. So, on behalf of Alkem, it is our utmost pleasure to extend a warm welcome to Dr. Shushruth Bandyopadhyay. Sir, your impressive credentials and vast experience in critical care medicine speak volumes about your dedication and expertise. So, as a director of critical care medicine at Amri Hospitals in Kolkata, your contributions to medical community has been invaluable. So we are very confident that your insights and your knowledge will enrich today's session. So without much delay, we welcome you, sir. And may I please request Allad or Mr. Prasanta to present a bouquet to sir as a token of our, Pinaki, sorry, as a token of our deep appreciation. Thank you.
Thank you, ma'am, for the kind introduction, and thanks to the Alkem team for this invitation. Today, we'll be talking about one of the, how do you call it, old but still very pertinent antibiotic in our armamentarium. And we have been using this for more than 2 decades now. I think almost 3 decades we have been using this. But still it has got in specific places, it is sort of irrepressible. We'll be talking about ceftriaxone, but before that we'll get some idea about what is the scenario in India about the infections as well as ICU infections, what the scenario in India is. So the magnitude of the problem, ICU infections are definitely an important cause of mortality and mortality across the globe. There might be some differences in incidences or prevalences, but then everywhere it is, ICUs are not free from infections. The patients are ill, they are at that point of time, they are somehow compromised immunologically, they have got lines, they have got to get broad spectrum antibiotics for some reason, and they have got tubes. And so all these things, they make these patients very susceptible to catch new infections, and these infections sometimes are killers. Global scenario of ICU infections are different from Indian ICUs. Indian ICUs increase infections from gram-negative organisms, increasing incidence of MDR gram-negative organisms in ICUs, and they are a threat. So this is, I don't know whether you can read the, smaller prints, but then this is WHO priority list of antibiotic resistant bacteria. WHO has already pointed out that antibiotic resistance remains one of the biggest menaces of present decade or present millennia even. So that is how we need to address them in war footing. Basically, the bacteria are becoming smarter, they are getting resistance day by day, and we are not keeping up with that pace in producing newer antibiotics or newer modes of treatment to handle this multidrug resistant bacteria. So critical priority one are this Acinetobacter baumannii, which are carbapenem resistance. This is also called CRAB, carbapenem resistant Acinetobacter baumannii. Then Pseudomonas aeruginosa, these are MBL producing, they are multidrug resistance, they are also carbapenem resistant. And Enterobacteriaceae, mostly Klebsiella pneumoniae, which are carbapenem resistant. Then priority number 2 are high, these are Enterococcus, which are vancomycin resistant, Staphylococcal, which are vancomycin resistant, and then Helicobacter pylori, Campylobacteria, Salmonella species which are fluoroquinolone resistant. These are rampant in the community right now. And Neisseria gonorrhea, which are third generation cephalosporin resistant. And medium level, alarm has been raised against streptopneumonia, which are resistant to penicillin, Haemophilus resistant to ampicillin, and Shigella resistant to fluoroquinolones. So these are the bacteria which are creating problems. So previously some standard therapies which were used have become sort of obsolete, or right now they do not work well. Say in a severe Klebsiella pneumonia, pneumonia with septic shock, previously our choice would have been meropenem, but now we know if that is a hospital acquired infection, there is almost 60–70% chance that the Klebsiella would be resistant to meropenem. In some hospitals it is even higher. So intensive care in India, how does it differ from Western world? This is basically Dr. Chaudhary's paper, and this is 2017. The scenario has slightly changed. Right now, even the West is facing more and more resistant gram-negatives, but still now, the West somehow has got a higher percentage of gram-positives than India. See, this is all ICUs, this is Western European ICUs, this is Asian ICUs, and this is also from SOAP study. These are also European ICUs that on the trial. So you can see basically in Western European, the positive isolates are 72% of the isolates. Indian Asian ICUs, it is 66.7. In gram-positive of Western ICUs, they are 49%. Almost half of the patients are gram-positive, ICU-acquired infections. In India, there are only 1/3. Gram-negatives, half, and this is India, you can see almost 75% are gram-negatives. Anaerobes, more in Western ICUs, almost double that of Indian ICUs. Fungi, almost same, 20:17. And viral parasites 1.4, 2.6, and others. This is basically from the EPIC data. EPIC was one point prevalence study of ICU infections. This was done long back, but then it was very exhaustive study across the world. So you can see Asian ICU, the pattern you can see. 75% are gram-negative bacteria. So if you see of the gram-negative bacteria, the E. coli, the Enterobacteriaceae, the Klebsiella, and the Pseudomonas, they were the main culprits at the time. EPIC data, though this paper is 2017, EPIC data is much older. I think it was 2005 or 4 where the EPIC data came. So, but right now we have got an addition. The Acinetobacter possibly will climb here, and possibly Pseudomonas will go down a bit in the Indian ICUs. Around 75% to 80% organisms were Enterobacteriaceae and Pseudomonas aeruginosa. So these are some other trials across India. This is from North India, West India, and East India. You can see that gram-positive isolates, gram-negative isolates are much higher gram-positive 16%, gram-positive 4.7%, 11%, 10%. Vis-a-vis gram-negative 76%, 93%, 84%, and 75%. And fungi, of course, we previously thought that our ICUs are free from fungus, but we know that large chunk, even some trials have shown, possibly in ICU-acquired infection, among the first 5 infections, there are invasive candidiasis might be one of them, depending on the type of the ICU or the demography, etc. So this, again, the same papers with another Padavardhan's paper. You can see the pattern remains generally same, that the gram-positives are smaller in number, gram-negatives are more extensive in Indian ICUs. So 55% gram-positives, 55% gram-negatives in this trial, 73% in this trial, 66, 59, and 65. So this bacteria, they cause almost half or sometimes 2/3 of all ICU-acquired infections. E. coli, Enterobacter, Klebsiella, Pseudomonas, and Acinetobacter. Nowadays, Acinetobacter has come in a big way. With this picture, so we know we are coming to this drug, which was, when it was launched, basically we have seen the launch of the 3rd generation cephalosporins. These were in the late 80s when we were just passing out of medical schools. So we were introduced at that time. I can remember the company which launched cefotaxime. It was supposed to be a miracle drug. They used to show a video where a patient with pneumonia and respiratory failure, panting, there were not many ventilators at the point of time, in high flow oxygen, given cefotaxime, and in 12 hours time the patient could be seen smiling and having a cup of tea or something like that. So that was the idea at that point of time. There were miracle drugs, but right now they have been extensively used. Even in community we get ESBL producing, extended spectrum beta-lactamase producing bacteria, which are generally resistant to this 3rd generation cephalosporins. But one of the main, or one of the strong member of that 3rd generation cephalosporin group was ceftriaxone. So ceftriaxone is a complete, it has had good, it has got an excellent absorption from IM, as well as if you give it IV, after 1 gram IV dose, concentration in 1 to 3 hours, rapid rise in concentration, and it concentrates well in the gastrointestinal tract, gallbladder, cystic duct, gallbladder wall. Pharmacokinetic data obtained after the slow intravenous administration of 2 grams of ceftriaxone over 30 minutes showed serum concentration about 15 milligram per ml after 12 hours and 20 milligram per ml after 24 hours. And it has got extensive protein binding. Almost 80 to 90% of the drug is protein bound and at therapeutic concentrations. So this is, if we go back to cephalosporins. Cephalosporins, they came into the picture somewhere in the late 60s. They started getting cephalosporins, and they were had a broader spectrum and more stable than penicillins at that point of time. So 1st generation cephalosporins were cefazolin, cefalexin, cefadroxil. They had mostly a gram-positive coverage. Till we use this cefazolin, it has got an excellent action against methicillin-sensitive Staphylococcus aureus. 2nd generation were the cefuroxime, cefaclor, cefuroxime, acetyl, and cefoxetine. So they had mostly gram-positive, but also a reasonable amount of gram-negative coverage. Cefuroxime, still now it is used. 3rd generation cephalosporin, cefotaxime, ceftriaxone, ceftazidime, cefoperazone, cefixime, and cefpodoxime. So these are the oral ones, and these are the injectable ones. They have got more gram-negative than gram-positive, but still they have got some gram-positive effects, of which ceftriaxone and cefotaxime perhaps have got better gram-positive coverage. And 4th generation, cefepime and cefpirone, they have got more gram-negative coverage. And 5th generation, right now it has come in the market maybe last 2 years or 3 years. It is ceftaroline. It is almost same as this, but it also has got a good MRSA coverage. So that sets it out from the other higher generation cephalosporins. So you can see the arrow here. More you go to the lower generations, more gram-positive, better gram-positive coverage is this. These are not worse. They've got better gram-positive coverage. But more you go on the higher generation, they've just got a better gram-negative coverage. So you can see where the ceftriaxone is supposed to work. It works in Staphylococcus aureus, of course, the MSSA, Staphylococcus epidermidis, again, which is not medicine resistant. Streptococcus pneumoniae in Southern Europe. We are having a chat. In Southern Europe, possibly there is a large number of species of Streptococcus which are resistant to third generation cephalosporin. I don't think still the picture is like that in India. Most of the Streptococcus pneumonia, at least in our hospital, they are sensitive to ceftriaxone. Streptococcus pyogenes, viridans streptococci, and Streptococcus agalacticae. And among the gram negatives, unless they are ESBL producing E. coli, Haemophilus, Klebsiella, gonorrhea, Neisseria meningitis, Salmonella. So these are all sensitive to ceftriaxone. But as you know that nowadays in community there is a lot of ESBL producing drugs. We have got several reasons of that, but then that you should be careful about. And anaerobes, it also has got a reasonable anaerobic coverage, bacteroids, Peptostreptococci, that is the anaerobic streptococci and Clostridium species, they are covered by, well covered by this ceftriaxone. But possibly they would not be effective against this Faecalis and Faecium enterococci, sorry. The dosage, the pediatrics is 100 ml per kg per day, and adult is 1 to 2 grams per kg IV, 7 to 10 days. Basically, for up to even serious infection, once daily ceftriaxone might be a good option, and possibly 2 grams is the dose in at least in the severe infections, 2 grams once a day. Indications in adults for the treatment of, it is recommended for complicated intra-abdominal infections, provided the germs are sensitive. Complicated urinary tract infections, same, including pyelonephritis. Hospital-acquired pneumonia, including ventilator-associated pneumonia with susceptible gram-negative microorganisms, as I've told you. That will depend on the picture or the usual flora in the hospital. If they are sensitive non-ESBL producers, this remains an excellent drug. Skin structure infections. It is also effective in uncomplicated gonorrhea, bone and joint infections, meningitis. It's we are having a chat basically for community-acquired meningitis in bacterial meningitis in India. Right now, people often practice a combination of vancomycin with meropenem, which I feel we overdo, because most of the community-acquired meningitis, they are either Streptococcus meningitis or meningococcus or Neisseria meningitis or Streptococcus pneumoniae. Sometimes there also you have got Haemophilus or Legionella. So, sorry, Listeria. So in these cases, possibly you'd be having ceftriaxone and ampicillin plus minus would be good enough to cover them. So we don't need a vancomycin, because still in India we don't have too many pneumococcus which are resistant to third generation cephalosporin. They're mostly susceptible. Of course, you can have the hospital flora and check. So we don't need vancomycin. And meropenem for community-acquired meningitis is very unusual, unless the patient has got specific like previous surgery, brain surgery or brain trauma, or maybe middle ear infections, extremes of age. So these are the points where you might be using meropenem. Otherwise, it should not be used. It did not be used in a community-acquired meningitis. And bacterial septicemia, surgical prophylaxis. Of course, ceftriaxone has been also big drug for our Salmonella typhi infections. Ceftriaxone can be used as a first-line treatment for infections due to gram-negative rods other than Pseudomonas. Second-line treatment that is for infections due to non-enterococcal streptococcal species in patients allergic to penicillin. So this is basically if you are not, but nowadays who uses penicillin? Not much. It was in between not even available. Now it is not available. Rare infections due to the gram-positive anaerobes organisms such as Propionibacterium or Peptostreptococcus. Peptostreptococcus is not that unusual. You get them. So ceftriaxone is commonly prescribed as third generation of parenteral cephalosporin, highly stable to beta-lactamases, not the extended spectrum beta-lactamases. Penicillin is particularly those produced by gram-negative bacteria. High potential against all Enterobacteriaceae, Haemophilus influenzae, Neisseria, and most of the gram-positive cocci. The half-life of ceftriaxone is 5.8 to 8.7 hours, prolonged serum half-life, which permits once or twice daily dosing, unlike the parenteral cephalosporin. This is one of the advantages. Unlike the other beta-lactams, you don't need to give them in multiple split injections, bolus. Concentration may be subtherapeutic if ICU patients, particularly those with hypoalbuminemia. As I told you, it is 80%, more than 80%, 90% protein bound. If the patient has got a critical hypoalbuminemia, patients with albumin less than 2 or near 2, there it might not be bound to protein. So free drug is more susceptible to excretion through urine, and you may not maintain the drug level in the blood for quite some time. It's mixed clearance. It is cleared both by kidneys as well as the bile, almost half-half. The pharmacokinetic properties of ceftriaxone show little change in patients with renal or hepatic failure, even when severe. So you don't need to adjust the dose even the patient has got a severe renal failure, liver failure, because the other clearance system takes over. If the patient has got a renal failure, the patient will excrete the drug through bile and vice versa. In patients with renal failure, decrease in urinary excretion is compensated by increase in biliary excretion. So that is the advantage of ceftriaxone. So basically, whenever the patient has got a serious infection or early sepsis, what happens, there are some changes in the body basically. So there are a thing called leaky capillaries, which increase the volume of distribution. Volume of distribution, I think we all understand, basically when you give a drug, it spreads into several compartments into the body. So some drugs, they say spreads into some specific compartment. Some drugs, they spread into a broader number of compartments. Basically, these are water-soluble drugs. I'll give you the list afterwards. Ceftriaxone is a water-soluble drug, so it is not a lipophilic drug. So it cannot go through the cell membranes, etc. So it is only spread among, say, intravascular spaces, extravascular subcutaneous spaces, so and maybe biliary area. So there are some specific areas where this drug is spread. So its volume of distribution is a certain volume. So if you think that is the volume of distribution, you have given a certain dose of drug, it would be spread and it will have a concentration. But what happens when there is a sepsis, there are leaky capillaries, the volume of distribution opens up. The drug starts spreading into several other areas. So suddenly the same drug which was in such a big room has been thrown into a room which is a bigger room. So the concentration automatically drops. So that might give some problem in the concentration, achieving the therapeutic concentration. There is altered protein binding, and so free drug, as I've told you, can be easily excreted by urine. Initially in sepsis, there is a increased cardiac output which causes increased lateral clearance, increased GFR. So that might also increase drug clearance. And there might be extracorporeal circuits, so like dialysis, etc., where it is going on, and end organ dysfunction. So when the patient starts getting organ dysfunction, like kidney failure, etc., only then the drug starts accumulating, and then the drug may reveal a steady state. Sometimes it may go higher than normal state. So that's very important that initially in sepsis, all drugs, they need to be given in full doses. Even if the patient has got an absolute renal shutdown, for first 1 or 2 days, you need to give the full dose of the drug. Change in pharmacokinetic parameters for the antimicrobials, according to as I've told you that there are 2 types of drugs, hydrophilic antibiotics and lipophilic. The lipophilic have a large volume of distribution, so it does not change much even in sepsis. Already the volume of distribution is quite large. So typical drugs are fluoroquinolones, macrolides, rifampin, TG-cycline. They have got a huge volume of distribution. But when there is, even in sepsis, the large volume of distribution remains, so not much change in concentration. But drugs like beta-lactams, aminoglycosides, glycopeptides, suddenly if the volume of distribution increases, then what happens? The drug concentration drops. And that may create problem for the achieving the therapeutic goal. All beta-lactams. The same, that and that also increases the clearance, and there might be a paradoxical drop in the drug concentration in the body. Critically ill patients with sepsis receive administration of intravenous fluids as standard management, and that also causes dilution of the drug. When hypotension persists, vasopressor agents are prescribed. Some of these vasopressor agents will increase cardiac output, and that will increase GFR in turn, and that might increase drug clearance. And in absence of significant organ dysfunction, there is an increased renal perfusion and consequently increase creatinine clearance or GFR. This is called augmented renal clearance, and this might cause a drop in the blood concentration early in the sepsis. That's what happens. And change in the protein binding, as I've told you, if the albumin is too low, then there will be lots of free drug in the blood which is susceptible to augmented renal clearance. This is the pharmacokinetics of once daily dosing of ceftriaxone in critically ill patients. And this is basically creatinine clearance with less than 60, 1 gram twice daily is the ceftriaxone, or you can give 2 grams once daily, 61 to 139, 1 gram 3 times daily, or 2 grams twice daily, whatever you want to give. So 2 to 4 grams is the daily dose of ceftriaxone. It can be given as split twice daily, or it can be given as a single dose. So unmet needs, a ceftriaxone dose of 1 gram twice daily is likely to therapeutic patients with creatinine clearance of less than 100 ml. But initially in sepsis and severe infection, it may be inadequate. Critically ill patients with normal renal function associated with hypoalbuminemia, increased volume of distribution, leads to an augmented renal clearance of ceftriaxone. So here, the dose needs to be possibly increased. In patients with renal failure, they decrease in urinary excretion compensated by increase in bile excretion. So actually, you don't need to reduce much the dose of ceftriaxone even if the patient has got a renal shutdown. Attainment of ceftriaxone, this is PK, pharmacokinetic by pharmacodynamic target has been associated with shorter length of ICU stay. So this is true for all drugs. If you go by the PK/PD, you know how much drug we are giving, how much the concentration, and how much extra drug or less drug we need to give exactly. So that solves many problems, and that makes the drug more effective. So general dosing concentration, we know in severe infections, often antibiotics, we use a loading dose, even with other maybe carbapenems to use a loading dose. Reduce bacterial susceptibility, reduce bacterial susceptibility infected with a higher MIC isolate. So this is one thing where maybe I require ceftriaxone. Some are borderline resistant bacteria. And there is also a thing called a sort of inoculum effect, where the large volume of bacteria may be difficult for a standard therapeutic dose to handle, of an antibiotic to handle the bugs, so you might need a bigger dose. Augmented renal clearance and hypoalbuminemia. All this might call for a higher than normal dose of an antibiotic. Efficacy and safety, so we are giving these big doses, are they safe? Comparison of clinical outcomes among intensive care unit patients receiving 1 or 2 grams of ceftriaxone daily. So this is the retrospective trial of ICU patient receiving intravenous empirical ceftriaxone in non-CNS infection was conducted. Basically, CNS infection required a higher dose. Patients more than 18 years of age were admitted with one of the designated ICUs, received less than or equal to 2 grams of empiric ceftriaxone daily for 72 hours ICU admission, and had at least one serum albumin concentration obtained within 24 hours of ceftriaxone, and categorized as receiving ceftriaxone 1 gram or 2 grams daily. There are 2 groups basically. So you can see the treatment failure in UTI is almost 33% if it was 1 gram, and if it was 0%, it was 2 grams. Treatment failure in patients with SOFA score of more than 10, this is the serious patients. Again, the treatment failure was higher in the ceftriaxone 1 gram, and it was much lower in the ceftriaxone 2 grams. In the ceftriaxone 1 gram, it was more patients who had treatment failure than who had successful outcomes. So you can see that it was inadequate. Overall treatment failure was 20% in case of ceftriaxone 1 gram and about 6% in ceftriaxone 2 gram, which was pretty good. That is more than 94% patients were successfully treated. Treatment failure in hypoalbuminemia, again you can see 30% versus 9.7, almost 10%. No cases of antibiotic escalation among who received 2 grams daily. They did not require an increase in antibiotic escalation. This means that the patient is going bad and I've got to increase the antibiotic dose or go for a higher antibiotic, 10 patients, 9.4% in the 1 point daily group required antibiotic escalation, 8 for pneumonia and 2 for urinary tract infection. There was no difference in adverse effects between the 2 groups. So 2 gram remains as safe as 1 gram. Clostridium difficile associated diarrhea diagnosed by PCR was confirmed by subsequent treatment with enteral vancomycin. The median duration of ceftriaxone therapy was 1 day longer in the 2 gram group, 6 days compared to 5 days in 1 gram group. Well, this does not mean much. But then you can see that 2 gram is much more effective and equally safe or as safe as 1 gram. 1 gram IVBD you can give, 1 gram, no, that was total 1 gram per day and 2 gram per day. We are using much less. That I was having a chat before this talk, and basically when we use ceftriaxone, we use higher dose. We use 4 grams of ceftriaxone. That can be given as 2 gram twice daily, or that even can be given as 4 gram once daily for ceftriaxone. We use 2 grams twice daily for all infections. But of course, our what do you say? There is a bias that we use only in ICU. So ICU patients, they have got more serious illnesses or whatever the indication might be. If they're meningitis, anyway, the dose is 2 gram twice daily. So this is basically the association between basically the predictors of outcome, that is higher SOFA score, creatinine clearance at 72 hours, and ceftriaxone 2 gram dose. If you give a 2 gram dose, the results were much better. This is a comparison between ertapenem and ceftriaxone, where they are both the bacteria susceptible to both the drugs. So this is one thing you should understand. A broader spectrum or a higher group of antibiotic does not actually mean killing power. Suppose the example, crudely what I say, that example is that suppose a patient has got a thing called an MSSA, methicillin sensitive staph aureus. You might think of giving this patient a vancomycin or a, say teicoplanin or a linezolid. Basically the advantages of all these 3 drugs are there effective against MRSA. But you can also choose to give this patient, say, flucloxacillin or a cefazolin, which do not act against MRSA. But if the patient is susceptible, MSSA, these 2 drugs, cefazolin or flucloxacillin, will kill this bacteria much better and faster than those stronger drugs, that is vancomycin, teicoplanin or linezolid. And the outcome would be better. So it has been proven by trials in pneumonia that if the patient is susceptible to, these drugs, it has got, vancomycin has gotten worse outcome, unless the bug is MRSA. So that has been already proven. So that you should differentiate between just, say, meropenem. Fine, meropenem is fine, but meropenem does not mean that it will kill the bacteria faster than a ceftriaxone in a susceptible state. Suppose the patient has got a streptococcus pneumoniae. They are susceptible to ceftriaxone. The ceftriaxone will be a very good, efficient killer of the bug. And you don't need to go to meropenem, and meropenem may not be killing the bug as fast. Even though it has got a broader spectrum, it might be effective against ESBL producers, it might be effective against MC, that's a different issue. So these things are compartmentalized and they do not go hand in hand. So that is, you should understand that. So you can see the clinical response for ertapenem and ceftriaxone, they are almost neck and neck. In fact, ceftriaxone is slightly better. This is moxifloxacillin, non-inferiority trial, where it has shown that ceftriaxone 2 gram given once daily is same as moxifloxacillin 400 once daily. Clinical response, here the ceftriaxone was, as though these were intra-abdominal infections. I told you, ceftriaxone does not act against this Enterococcus faecalis faecium, etc. So there is, metronidazole was added to this regime. And ceftriaxone plus metronidazole versus moxifloxacillin alone, it was tried in intra-abdominal infections, and you can see the outcomes. Success rate, ceftriaxone 96, moxifloxacillin 90. Bacteriological cure, that is cultures negative after a certain amount of treatment, 95% is to 89%. Overall adverse events, moxifloxacillin had a slightly higher adverse incidence of higher adverse events. And this is versus tigecycline. Again, tigecycline has got a very broad spectrum. It is effective against MRSA, it is effective against anaerobes, it is effective against everything except Pseudomonas, almost everything except Pseudomonas. So 467 patients, it was ceftriaxone 2 grams once daily plus metronidazole. I told you ceftriaxone will need metronidazole to cover all the anaerobes, versus tigecycline 100 milligram followed by 50-12 hourly. Primary endpoint was clinical cure rate, microbiological eradication at the clinical cure rate was 74% versus 70%. But one thing we should understand, right now the recommendation, at least in ICU for tigecycline, is not 100 then 50 BD. It is 200 and then 100 BD. Microbiological eradication better with ceftriaxone, metronidazole. So these are the trials which showed if the I fully agree that not all our bacteria right now are susceptible to or susceptible to ceftriaxone. They are ESBL producers, they are MPC producers, they are even higher carbapenem MS producers. But if they are not community acquired, then ceftriaxone remains a very attractive treatment option. In the sense, it is a good killer, fast killer. It is got excellent tissue penetration across the body, and it has got minimal adverse effects. So, with this clinical cases, old wine in a new bottle, recent studies have shed light on the benefits of administering ceftriaxone in a single dose of 2 grams. There is a case report. Mrs. RT, 60 years female, admitted with left-sided flank pain and dysuria and malaise. No comorbidities, prior history of hernia repair. USG shows left vesicular junction stone and underwent a cystoscopy of left. This is reverse intrarenal surgery and a double J stenting. Initiated on IV ceftriaxone 2 grams from day 1, patient was rendered pain-free after 6 hours and tolerated the procedure well, noted to have an uneventful course of stay. No fever spikes noted, no culture growths, and no chills post-antibiotics administration. Discharge on day 4 with oral antibiotics. In view of hemodynamic stability and improved general condition, no need for escalation was deemed necessary. So it could be successfully countered with ceftriaxone. This is a healthy female, 47 years, brought from outside hospital with malaise and dyspnea, aggravated by exertion and chest discomfort, noted to have an accelerated hypertension, positive cardiac enzymes, and reduced ejection fraction and associated acute kidney injury progressing to oligoanuria. Admitted to the heart center, arterial catheterization, temporary hemodialysis, catheter insertion, and triple lumen central venous catheterization done, and continuous renal replacement therapy initiated in view of metabolic acidosis and oligoanuria after the diuretic trial failed. Also initiated on 2 grams ceftriaxone for antibiotics, cover in view of the multiple invasive lines and monitoring devices. This is again, we are having a chat. We do not use this usually, but just putting in lines do not call for a preventive antibiotic. But if there was an emergency, you were not very sure that you could maintain the sterility, then you might be justified in adding antibiotics. The patient tolerated around 32 hours of CRRT, following which a switch to the sled was performed, despite multiple hospital exposure prior to admission at NSSH, max invasive lines and catheters and prolonged ICU stay. Patient was noted to clinically improve, no rise in infection markers, and improved all aspects with no need for antibiotic escalation. In view of patient's young age and clinical presentation, autoimmune workup and septic workup are dispatched, which are all noted to be negative. At any given of time, no septicemia is noted. So, at the end of our talk, we come to a conclusion. Ceftriaxone is among the most commonly utilized antibiotics owing to its high potency, wide spectrum of activity, and low risk of toxicity. A successful PKPD target attainment was defined as unbound trough concentration above 1 or 4 milligram per liter throughout the whole dosing interval. Unbound ceftriaxone predominant excreted by kidney. Consequently, attainment of the PKPD target may be compromised in patients with augmented renal clearance, ARC, in risk of therapeutic failure. Increased ceftriaxone doses to achieve this concentration versus MIC ratio of more than 1 in critically ill patients with reduced albumin concentration or increasing creatinine clearance. So that you should be careful. At least early in the sepsis, the dose should be full or even sometimes higher than normal. Patients with augmented renal clearance or those infected with higher MIC isolate require a 3 to 4 gram dose per day, either in divided doses or administered as a continuous infusion to achieve a concentration minimum versus MIC of more than 1. Attainment of the ceftriaxone PKPD target has been associated with shorter length of ICU stay. That is true for all antibiotics. Higher rates of clinical cure, microbial eradication, and suppression of resistance. That's also very important. Timely prediction of augmented renal clearance in combination of Bayes and forecasting of unbound ceftriaxone exposure has been potential to improve target attainment in critically ill patients. Well, that would be difficult or impractical, but remember that at least initially, even with renal compromise, you give the full dose. Sometimes you may think of giving loading dose too. Optimization of ceftriaxone dose in era of antimicrobial stewardship has been suggested to make less resistant pathogen. This is also very important, that unnecessary do not use broad spectrums. You have started a patient with, as I've told you, that come with a pneumonia, with a respiratory failure, with shock, and you of course put the patient on meropenem and whatever, Targocid or whatever it is you have put. But after the culture comes, you see that the patient has got Streptococcus pneumoniae as the positive organism, sensitive to a ceftriaxone maybe. So you are supposed to de-escalate. Stop meropenem, stop that MRSA, anti-MRSA drug and put into a ceftriaxone. The problem is that patients are valuable, doctors, they feel jittery, and they've got a term like don't rock the boat. The patient is improving, why do you bother? Let the antibiotics finish anyway, we're getting over. But this is one thing, you'll save this patient only to kill your next patient, because the next patient will be having a meropenem resistant strain, unnecessary use of meropenem. So that you should be very honest about. Of course, you need a good microbiology lab which you can trust, and you should need to send the cultures before you start your antibiotics to pick up the germs, bugs. But then after that, remain honest to your cultures. Thank you. So I'd be open to comments.
Yeah, sir, indeed it was quite elaborative with the great insight about overall patients in critical care as well as managing the patient with the antibiotic. And there are several things which we could able to learn, sir. I got couple of comments online as well. I was trying to gauge those. As we said that ceftriaxone 1 gram twice daily is something which has been regularly practiced across the country. And you have given a very clear-cut segmentation and the understanding about 2 gram. And then 2 gram definitely as a starting dose, especially in ICU patients. That is what the literature is also saying. So either, and then especially in elevated renal clearance, as well as higher SOFA score or like hypoalbuminemia, wherein you definitely require the high dose of antibiotic. So there is a clear segmentations that in the trade, typically in typhoid or UTI, RTI, wherein 1 gram twice daily is perfectly all right. But when it comes to critically ill patient in ICU, starting with 2 gram is something which is quite helpful and got a clear understanding about it, sir. So there are a couple of questions my colleague Dr. Pooja has gathered online. So I would request her to quickly toss that. And even the audience also sitting, probably we can take those questions from the audience. If at all any specific questions pertaining to the topic, or else you want Dr. Shushrup to comment on something which is probably challenging for you in day-to-day practice in critically ill patient management. So I would request the audience, if at all any questions or input or insight if you required.
Yeah.
Yes, sir. Is it regularly advisable to do the de-escalation, or do we continue? That's most of the times we continue the same drug which has been used. That's what the practice is.
That basically many people, they have got this saying which is do not rock the boat. Now the patient is settling down, the patient has become better, coming out of the ventilator, off shock. Now why do you want to create a trouble and take off the problem? I tell you that we are not following the science well. Basically, when meropenem was launched, at the same time, the innovator company, they started a drive called AIM at that point of time. I remember early in the 2000s. That is called Academy of Infection Management. They drew our attention to a few facts which were good. It was science. That basically what they said, this was Anand Kumar, a Canadian Indian's paper, famous paper, which showed that in septic shock patients, 1 hour delay in giving appropriate antibiotic increases the mortality by 6%. Very clearly proven. And it was afterwards, validated also. The delay in giving adequate. Adequate, what do you mean by adequate? That means a germ, you have got a germ, the antibiotic should be effective against that class. That you have got gram-positive, the antibiotic should be against gram-positive, not a anti-gram-negative antibiotic. Next, the bacteria has to be susceptible. If the bacteria is resistant to that antibiotic, the antibiotic does not remain an adequate antibiotic. So that should be given, that was as early as possible. They were using a term by Paul Ehrlich, that is hit hard, hit fast. Fine. So what happened is that they were telling, at that point they started telling that a large chunk of Indian community-acquired infections are ESBL producers, extended spectrum beta-lactamase producers. These ESBL producers, they are resistant to most of the penicillins, the cephalosporins, the fluoroquinolones. They could be handled by what is called a BL-BLA combination, like say cefuroxime sulbactam or piperacin tazobactam, or carbapenems at that point of time. The disadvantage with cefuroxime sulbactam or piperacillin tazobactam, that is the BLBLI, beta-lactamase inhibitor combinations, was that they had a thing called an inoculum effect. That is, if the infection was too large, then the beta-lactamase inhibitor part of that, that is the tazobactam or the sulbactam, that used to get spent in first few hours, what you are giving. So leaving the unguarded beta-lactam to work, and against which the bacteria was already resistant, was producing an ESBL. So they did not work. They, outside the in vitro, they showed good susceptibility, but once given in vivo, it showed a poor susceptibility. So that point of time, these AIM people, they told that then you should always give a meropenem in a patient who was in septic shock. The point is that the septic shock part of the sentence, it got muted over years. So everybody thought that any patient coming with infection, you should need to give meropenem. Otherwise, there is mortality. It is not true. I had a chance to talk with even Dr. Kumar himself. He said, my trial is good only for septic shock patient. Just a patient coming with a 20,000 count does not call for a meropenem. But our habit has become that. And that awareness program was so successful. People, they switched, but they forgot. At that point of time, they were also teaching that you send the cultures, and whenever the culture says that it is sensitive to something lesser, you go de-escalate. That was also taught at that time, but that again was forgotten. So basically, we only took a part of the knowledge that we need to use meropenem, but we forgot that these two main teachings, that only in septic shock patients or patients where the bacteria susceptible to narrower spectrum antibiotics, you should de-escalate. De-escalate, it has been shown in papers, it causes better outcomes. No issue with that. Provided, of course, that you have got a good culture, you've got this thing. So that requires some effort, some amount of knowledge, etc. Everybody wants that I should have a fill it, shut it, and forget it drug. Forget about too much thinking, forget about trying to get a syndrome, forget about recurrent cultures, why bother? Just give a drug and forget about it. And particularly if the background of the doctor is not medical or medicine, sorry, not medical, not medicine. So non-medicine, say surgery or something like that, they do not want much trouble. I've done a surgery, why bother? I want to forget about that. There is again a typical dialogue, first control the infection, that's the easiest thing to do. With that, over years, we have given rise to more and more resistant strain. We have spent lots of money on meropenem. It has become cheaper than earlier, but then we have rampantly used these penems. And so much of faith it has generated, as I've told you, even a patient with a head injury, a patient with a sleeping pill overdose, a patient with a myocardial infarction, even with a slight rise in blood count, etc. If there is some shock because of any reason, I mean hemorrhagic shock, everybody wants to give meropenem. The patient should not die without getting meropenem. So that is basically silly. So that is, you should know that, of course, you should be very careful about de-escalation, that you should not miss something. There was one, sorry, I'm going, maybe, but then there was one incident I remember, that there was a doctor who came with he was a surgeon. He brought in a patient with a cellulitis in the leg, and it was a fasciitis, etc. And the patient was in septic shock. The patient was put on meropenem, but once the cultures were sent, it was seen that it was a much simpler. I forgot it. I think it was an MSS or something. So we de-escalated. But the patient was not, after some time, the patient's improvement curve flattened out. The patient was not improving. I mean, initially improved a bit, but not a bit. So everybody was again, you shouldn't have stopped the meropenem, look, the blood count is not coming down, etc. So then we found that the patient was having pockets of pus in the compartments, I mean leg. So as it was a primary surgeon's case, we asked the surgeon, and he then drained the pus. And after draining, the patient again started improving. That is another part, that is source control. So had we not done the source control, we would have thought that the patient is not responding to a lesser antibiotic, and then gone into, again, back to meropenem without, again, much result. But after that, surgeon became so confident that every day he was coming and asking me, do I need to do another drainage or not? But there was no more pus, the patient was improving, everything was fine. But that is the thing. So these are the issues. I mean, our problem is that we have become so mentally dependent on meropenem. Anything goes wrong, we feel that, well, we shouldn't have stopped meropenem, or we should continue with meropenem. So that is what our basic idea is.
Any other questions?
plus?
Avibactam.
I don't think such a combination has come. Ceftriaxone with avibactam, has it come? Ceftazidime avibactam, yes.
Ceftriaxone plus avibactam.
I don't know. I don't know there is any ceftriaxone avibactam. This combination has not come yet. I mean, has not been recommended even. Ceftazidime avibactam has come.
That has come.
And people are also trying to get in aztreonam with avibactam. That's there. But ceftriaxone avibactam, I don't think.
There are 2 to 3 articles where ceftriaxone plus avibactam has been compared with meropenem.
Basically, the advantage of avibactam is what I understand is that it is a newer generation beta-lactamase inhibitor. It is a super beta-lactamase inhibitor that it is also active against carbapenems, which the other beta-lactamases are not. Another difference from the other beta-lactamases like tazobactam or sulbactam is that avibactam is reversibly bound. So as I've told that inoculum effect, that a large amount of bacteria has infected the body and producing a huge amount of ESBL or beta-lactamase. There you are giving a beta-lactamase inhibitor. What happens is that after some time the beta-lactamase part gets spent to handle that amount of this thing, because previous beta-lactamases were irreversibly bound. Once bound, it could not come out of that. So and that makes the beta-lactam vulnerable to the ESBLs. But avibactam is reversibly bound, so it will inactivate certain beta-lactamases, come out of it, again inactivate, so there is no inoculum effect. So theoretically, you can combine with many, antibiotics, I don't know, but I don't know, maybe articles would be there. People can even, publish an article if someone wants that I want to give erythromycin with avibactam, that can be done. But I don't think there is any standard recommendation of combining ceftriaxone with avibactam. So I have not seen that.
So we have a question from one of the online participants that what has been your experience with 4 gram per day in terms of safety?
Perfect. Nothing. Ceftriaxone is a very safe drug. You don't have any issues with that.
Okay. And what are the patients that you would prefer to give 4 gram, which is a maximum dose?
Basically, it is the standard dose for meningitis. 4 gram per day is standard dose for meningitis. That is already written. Or, as I've told you, I have got a bias because I'd be treating only patients in the ICU. There, the patients, they come, as I've told you, some of them we are treating with, say, these are Streptococcus pneumoniae, even with septic shock, etc. So, if we find that it is a culture positive like that, then we change to ceftriaxone. There we give 4 grams once a day. Yes.
Okay, any other questions? Anyone?
When we receive patients with immunocompromised patients with low count sepsis, probably after chemotherapy, so what should be the right approach in terms of antibiotics apart from the IV fluids and the inotropes? What should be the first shot?
There are 2 issues here. One, what you are talking about, is febrile neutropenia.
Yeah.
Febrile neutropenia, the recommendation right now is give a broader, higher cephalosporin, or if the ICU has got lots of ESBL MC, you can go for a carbapenem, and you can give also a gram positive depending on the flora. That you have to give empirically for at least 72 hours, and after that there is no improvement, you add an antifungal. That is the standard teaching for all febrile neutropenia patients.
Yes,
Whatever you are talking about fluid and inotrope is basically the patient on top of that also has got a shock.
Yes, sir.
So septic shock, fine, you will treat as a septic shock. One part is you are killing the bacteria, that will be give according to the guidelines and matching with your own hospital flora. If you feel your hospital does not have much ESBLs, you can persist with a 3rd generation cephalosporin with a gram positive coverage you want. And then if your hospital has got our hospital has got definitely MCs, ESBLs rampant.
Yes,
Forget about carbapenemases. So we would be giving carbapenems. 48 hours after that, the patient does not respond, we usually change to our main culprit or this Klebsiella CRE. So we get ceftazidime avibactam with or without aztreonam. We use that, and you can use
like the first shot should be like if you have to start, then the first shot should be carbapenem, or we should add targocid or tigecycline along with that.
Basically, as I told you, it is the flora. You need to cover. Usually, the bacteria, the germs are gram negatives. 90% are gram negatives. So you need to give a gram negative coverage. That can be a high generation cephalosporin, a BL by BLI, or a carbapenem. If your hospital has got a significant more than 20% of their ESBL producers or MC producers, then you have to use a carbapenem. I cannot take a chance in a septic shock patient.
Thank you.
If the patient is absolutely a severe shock, sometimes people want to cover the gram-positive too. Why bother, even if it is a 10% chance gram-positive? Then you can use Targocid. You can use, we use a lot of this. Right now we are also using ceftaroline, as I've told you. And if it is a community-acquired severe sepsis, even community-acquired, then we don't expect an MRSA to occur in community. So we can use, we often use cefazoline or flucloxacillin or even dicloxacillin.
Sir, I have a question. Like, is there any changes in the resistance pattern of these organisms post-COVID? Like, in your experience, have you seen any particular change or?
At that point of time, there was a lot of overuse of antibiotics. The COVID patients who came to ICU are very sick. We used to have a cutoff guided. I mean, it was not very, validated, but that is the best we could do. We used a cutoff of 1 for procalcitonin. If the patient had a procalcitonin of more than 1, used to add broad spectrum antibiotic. Else we has to take that whole thing is because of the COVID. Less than 1, because the patients often came with a high CRP, high count. That could have been because of primarily the COVID or a secondary bacterial infection. And as the patients were receiving high dose of steroid, they were also susceptible to secondary infections. So often the basic question whether the patient does have a bacterial infection or not, still we do not have a single point test to tell unless we get a culture, single point test to say yes or no. So we use by rule of thumb, we used to use that if the procalcitonin was less than 1, we did not add any antibiotic. If the procalcitonin was more than 1, we added broad spectrum antibiotic. At that time, definitely there was resistance charms because many patients were getting lots of antibiotics. But overall, as a community, I don't think there is much change. It's almost the same.
Thank you, sir. Yeah. Any other question, anyone?
Thank you.
Yeah, thank you so much, Dr. Shushruth. It was indeed a very insightful, discussion. Thank you so much for joining all of us for elite medical fraternity, speaker sir, and all those doctors, those are joined online as well. I'll just take very important 1 minute of yours to quickly brief that, as I said, that ceftriaxone is almost a 30 years old molecule, and we are amongst the pioneer in manufacturing and marketing ceftriaxone under the brand name of the Zone Exoini, first shot, sure shot. That's what we have been talking about. I would like to quickly bring to your notice that we, being a very sensitive, sensible and responsible organization, that we have undertaken a large-scale trial primarily into the government medical institute to ascertain that in the wake of growing antibiotic resistance, Alkem, the leader in the anti-infective therapy since past 3 decades, has actually partnered with 3 large government hospitals across the country, and those large government hospitals to ascertain that does ceftriaxone still works the way it used to be maybe 30 years, 20 years or 10 years before. So susceptibility and MIC, and the study is CISA 2023, that is ceftriaxone in vitro susceptibility study. Again gives once again the confidence that yes, Zone is a first shot, sure shot antibiotic. Next, this study is very interesting and is soon getting published as well. Next place, please. So, as I said, in vitro susceptibility of ceftriaxone in community acquired and nosocomial infection. So, essentially, both the samples were picked up from community as well as the hospitals in ICU, especially in gram negative and gram positive. And and then conducted in 3 large government hospitals, namely the SGPGI Lucknow, KEM Pune, and then in our own Calcutta, that is ICH, the Institute of Child Health. And essentially the samples were typically picked up blood, pus, urine, and cerebrospinal fluid, respiratory sample, ascitic fluid, and tissue. And it has been done with the help of the high media E strips. And then there were 4 antibiotics which were compared and contrasted. and namely ceftriaxone vis-a-vis the coamoxiclav, cefepime and then cefotaxime. And then very interesting that overall results, the results next, results at across all three centers, OPD, IPD, still the zone that ceftriaxone MIC is far more lesser than the comparing antibiotic, namely coamoxiclav, cefotaxime and cefepime. Moreover, as high as 70% of pseudomonas are seems to be found sensitive or intermediate sensitive to the ceftriaxone. The idea is why to go for a higher antibiotic. And moreover, last but not the least, the golden indication and the golden treatment for ceftriaxone, that is 100% staph aureus were sensitive to the ceftriaxone. This was something which is known to all of you, but this is once again proved the fact is that the 30-year-old molecule ceftriaxone is still effective and proves to be the first shot, sure shot antibiotic in all those community acquired pneumonia, in all those community acquired infection as well as in nosocomial infection. So once again, I would request each one of you to sincerely consider Zone, the first shot, sure shot injectable antibiotic, #1 prescribed antibiotic of Alkem corporate, and is there in market since last 2 decades. So for the vote of thanks, I would request Mr. Pinaki Samoy to please come forward and give the vote of thanks to the doctors and invite them for the next program. In fact, this study is soon getting published in journal called as Curious as well as in JAMA. So, like this, once the study gets published, so we'll get all those data to you, so that will add one more confidence and trust to you. Mr. Pinaki, please come forward.
Thank you very much, Alarji. And thank you very much all respected doctors, especially Sushruta sir, for your excellent presentation. We have not only seen the presentation, but it has been broadcasted to entire India. So this is our first journey after a long time. Because CISA study, what he has told, that after 15 years, Alkem only has taken this kind of initiative, that what ceftriaxone is in today's scenario. Because no such antibiotics are coming to the market, or we cannot develop such kind of antibiotics. Those can serve for the society more than 30 years. So I am requesting all of you, please continue with us in coming future, near future. We'll do this kind of more activities so that we can also overcome from this kind of situation, or we can develop for better antibiotics in coming days. Thank you all, and after this, I'll request all of you, so yeah, having a gala dinner, and before closing today's night or event, I'll request Prashant sir and Alarji once again to close the ceremony.
Thank you, Pinaki. Thank you very much, Sushruta sir, for excellent deliberation regarding ceftriaxone, usage of ceftriaxone, especially Zone. We as in ceftriaxone market, as a Zone brand name, we are the #1. Still, we are trying to give you some extra knowledge through Dr. Sushruta sir. So many thanks for audience of doctors of online, and many thanks to our physical doctors also, those who have come and spared their time for Alkem. We believe we are the antibiotic house. Definitely, sir, for your support, definitely you go #1 company once. Thank you very much. Thank you. Good night, everyone.
Doctor, your trust and confidence while prescribing a brand comes from its quality, thereby consistency in delivering results. Delivering a quality product that ensures consistent results needs to pass through stringent manufacturing processes. At Alkem, Zone is manufactured at state-of-the-art WHO and GMP certified Sikkim plant. Each and every vial of Zone passes through 50 different quality checks at different manufacturing steps. 11 checks done at cleaning, sterilization and drying of machine parts. 9 checks done at washing of vials. 9 checks done at sterilization and depyrogenation. 5 checks done at blending. 10 checks done at vial filling. 6 checks done at dispensing. Moreover, Zone is powered with advanced nanotechnology, which achieves particle size of less than 30 microns and helps in rapid and deeper penetration into infected tissues. 50 stringent quality checks powered with cutting-edge nanotechnology give Zone the X factor. Doctor, prescribe Alkem's #1 prescribed injectable antibiotic Zone with trust and confidence. Zone, the first shot, sure shot injectable antibiotic in typhoid fever, gastroenteritis, RTI, UTI and meningitis.